Well, welcome to our Pocus and Global Health Conference. Pocus is for point of care ultrasound, which is kind of a rapidly developing kind of skill in the practice of medicine. And I know that most of you guys may not be familiar with this, but hopefully by the end of our panel and a little bit of hands-on, you guys will get your hands dirty and you'll really understand what we do with Pocus. So my name is Alan Chim. I am an emergency physician. I started at All of You UCLA in 2012, and I've assumed multiple roles, but my current role is as Director of Ultrasound Education at the medical school here. And that involves there's 4 years of Pocus curriculum that's integrated within the traditional curriculum as well. And I'd like to introduce our panelists here. We have Dr. Ashley Yearwood, who is in interventional radiology, and she is going to speak about her experiences with Pocus and her home country of Grenada. And Dr. Jackie Shabata, she is the fellowship director of our Pocus fellowship program that's integrated with Harbor, All of You, Reagan, Santa Monica, as well as the VA. And she is my compatriot, I guess, at All of You. She's also full-time there. And then Dr. Pablo Aguilera, who is the Vice Dean for International Affairs at the Pontifical Catholic University in Chile. And he's also an emergency physician. He is also Pocus Fellowship trained, and he's done amazing work integrating Pocus into the practice of medicine in Chile. So, before I continue on, I think we should really give a round of applause to all of our coordinators. They're the ones behind the scenes that have been planning this out months ahead of time, and they really deserve all the credit for today. So I don't know if Stephanie is here or Ahmed, Naomi.
They're so busy coordinating.
Yeah, they're busy coordinating, I think, but yeah, they definitely deserve a round of applause. All right. Ashley, do you want to get started? Okay.
Good morning, everyone. My name's Ashley Yearwood. I am an interventional radiology resident at UCLA. I'm in my third year, and I am from the Caribbean. So I was born in Barbados and grew up in Grenada. It's okay if you've never heard of Grenada. Most people have not. So I've put a nice picture to show you my island, the first one. You can see in the second picture, just for perspective, we have California. See it nice and big, and then maybe at the end of that yellow arrow, a small pixel, that's Grenada. So with this in mind, I'm going to talk about my experiences using ultrasound in global health. We have a population of 100,000 people. We have one CT, one MRI for the whole country. So ultrasound really does play a role in patient care, as you can imagine. And forgive me for these pictures in advance. They're from my dad, who's a clinician at home, and dads and cameras never work out. So this is his ultrasound. You see, it's very simple. It's secondhand. There's just 2 probes, that's it. Compared to some of the ultrasounds at UCLA, it's, it's what we need. It works. So you can imagine that in this setting, a technology or device like ultrasound that's universally available, low cost, portable, relatively easy to use, and with a benign safety profile that provides real-time feedback is extremely useful. It's a game changer in a country like Grenada that lacks resources, lacks subspecialists in medicine. Clinicians back home actually consider ultrasound to be an extension of a physical exam. So, patients in the north of the island, to get to the main hospital would have to drive an hour. It's not as accessible as we would like it to be, but it is what it is. So it's just scattered throughout the island. We have these small clinics. And so a person comes with, for example, hematuria, and you do your physical exam and your history as you normally would, but the ultrasound's there, so, why not? Let's take a look. And in this first picture, the first patient, you can see that there's this black or anechoic bladder. And within that bladder is the whiter hyperechoic soft tissue structure. It's a bladder mass. So, in this setting, the clinician can say, go to the main hospital for further workups. In the second picture, on the other hand, it may be difficult to see, but let me close this so I can see. Yeah, so it's an ultrasound image of a kidney with hydronephrosis. So, in this setting, the clinician in the north of the island, where the big hospital is not nearby, can say that whatever the kidney stone that this patient's having is obstructing and causing the kidney to have hydronephrosis. And in this setting, it's helpful for them to go to the main hospital and get further workup because this obstruction can cause permanent damage to the kidney. Whereas if it were, say, a smaller kidney stone, you can send them home and say, it's probably going to pass with just hydration. So it's really helpful. It's really helpful to provide extra information that can allow triaging of the patients. Just trying to get it to, here we go. So another example, a person comes in with breast pain. You can see that this picture is a breast abscess, but there's another situation that my dad was telling me about. They saw a giant cyst. Now this cyst right there and then was able to be aspirated, so you use ultrasound guidance to place the needle and pull out all the fluid, and in this one-stop shop, if you will, it allowed treatment. And so that kind of brings me to my next point. Not only is ultrasound really helpful in terms of workup and diagnosing, but also in intervention. And I'm in interventional radiology, so this is particularly interesting for me. But just in general, in a country like Grenada, or any global health setting, to have this one device that can diagnose, triage, intervene, it really is an ideal kind of, modality. And this is just, I got this from the internet, showing the biopsy or a biopsy with that kind of fine white line going from the skin into the thyroid. That's the needle. It can be done bedside. It takes 15 minutes, depending on skill level, of course, but it's quick, it's easy, and it's really helpful. So just a couple takeaway points in my experience, especially being from Grenada, having the ultrasound, which is portable, low cost, accessible, all these features allow it to be a really useful modality. Number two, we can think of it as the extension of a physical exam. This prevents delay in patient care. It helps you, tell them when to go to the main hospital, when you can go home. It advances patient care in that way. And then takeaway three, a one-stop shop. So workup, diagnosis, intervention, all in one. And this is really important for a place without, if you will, resources and subspecialties. So we like ultrasound in Grenada. Thank you.
I'm Jackie. I am a physician in the emergency department, and I was going to start, but I do teach ultrasound in Tijuana. You can see here's the beautiful border, that's Playas. The beach is down on the northernmost part of TJ, which is really beautiful. That's where I stay every time I go and visit. But before I talk about what I'm doing down there, I just wanted to talk a little bit about my own personal global health journey, just to give you guys a sense of what it looked like for me. So what I thought it would look like when I was, who here is what year of, where in life are you all? Are you undergrad? How many people are undergrad? Okay. How many people are grad school? How many people are like somewhere in between? Okay, I love it. All right. Okay, now I have a good sense. So yeah, so I was sitting in undergrad at UCSD. I don't know if you guys know this library. And someone came to I knew because when I was in high school, I had an opportunity to go to Kenya and Tanzania to visit some family out there, actually. And I was just shocked at the disparities that existed in our world. I had no sense as a high school student in the Bay Area how some people were living their lives and how little resources there were and lack of health care and lack of clean water and all these things. And so that was very eye-opening to me as a teenager. And so I didn't know what I wanted to do, but I was like, I'm going to Africa. Like, things are not fair in the world, and that's what I'm going to do with my life. And as a college student, I was like, okay, how am I going to get there? I'm going to join the Peace Corps, and then I'm going to go to Africa, and I'm going to like help people. And that was my very simplistic view of what I was going to do in life. So I attended something like this, and there was a physician there who I was talking to afterwards, and I was like, I don't know what I'm going to do. I'm a psychology major and like maybe mental health, I don't know. And he was like, I was like, I don't know, I'm just going to like join the Peace Corps and then I'll figure it out. And he was like, go to medical school. And I was like, oh, but I want to go back to Africa. And he's like, go to medical school. And I was like, I had never really considered medical school. I didn't really think I was a science person. But I started thinking about it. And I took a trip to Ecuador, taking medical supplies down there. And in exchange, they let us sort of shadow in the hospitals and clinics. And I loved it. I fell in love with clinical medicine. I was like, oh, wow, this is really cool. And again, there's a lack of resources and a huge disparity. And this is maybe a practical skill that I could do. It seems really interesting. So I started looking more into medicine, got in my third year, like switched into pre-med and had to take all these classes and had a very long undergraduate stay. And so in reality, what I started to realize is that like this is more what life looks like, right? It's all over the place. It's not a straight line from A to Z at all. And so after I graduated, I wasn't ready to apply to school because I was behind on everything, had to take my MCAT and all of that. So during that time, I worked as a medical scribe in the emergency department. I loved emergency medicine, really fell in love with that, and it really drew home, it like nailed down the point to me that like I love clinical medicine. And ultimately, I did end up getting into medical school. I moved to Chicago, beautiful city. I was there for 4 years. Still very interested in global health. Like my interest was get back to Africa. And so I think it was my 4th year. I went to Zambia for a couple months, did some rotations out there, loved it, was like, yes, this is still what I'm gonna do. I moved to New York for residency. I did a 5-year residency in emergency medicine and internal medicine. These are residents sleeping because you don't sleep in residencies. You sleep in the hospital. It wasn't really that bad. We had beds. And well, sometimes it's that bad, I guess. It's great. You should all do it. And during that time, I was still very much like, I need to get back to Africa, but I couldn't figure out how to get there, so I started with going to Peru, and these were some residents in Peru that I was working with, and I was a 4th year, so I was a senior resident. I'm like, I'm gonna go down to Peru, and I'm gonna teach these guys emergency medicine. And then I got there, and I was like, how do you guys practice medicine here? Like, it was just such a different environment, different resources, and I realized, like, I was still in a position of learning a lot more than I had anything valuable to teach. There was some practical emergency medicine skills that I could teach, but really the one thing that everyone came to me for was teach me how to use an ultrasound. They had ultrasound machines, they had point-of-care ultrasound machines, meaning that they were at the bedside, but they didn't know how to use them. And like Grenada, even though Peru is a much bigger country than that little dot, they also don't use CT scans and MRIs. They're very, very limited there. And so if you want to do, everything was really still based on history and physical exam, which is great, but why guess what's going on when you can just look inside with technology? And they had the technology, they just didn't know how to use it. And so I was teaching a lot of ultrasound because I learned that in my emergency medicine training, and I realized I had a lot more you don't really know what you know until you try to teach something, and then you're like, oh man, do I have a lot to learn. So I started thinking about doing an ultrasound fellowship. My 5th year in residency, I went to Botswana. They were just starting an emergency medicine residency down there, so I was doing lots of lectures. But again, everybody's like, teach us ultrasound. We want to know ultrasound. And so this time I actually went down, prepared some ultrasound lectures, and started teaching ultrasound. And I was like, I really love this a lot. And so I decided to do an ultrasound fellowship to get some extra training, because again, I was like, here's a practical skill that I can take. But I also sort of felt like I was between doing an ultrasound fellowship and a global health fellowship, and I was like, I don't want to be pushed too much into the ultrasound world, because my heart and soul is going back to Africa. Like, this is my plan. I'm going to spoil this and let you know, like, I'm not in Africa right now. So I did my ultrasound fellowship. I came back to LA during my fellowship because I was really holding on to that global health ideal. I enrolled in the Fielding School of Public Health. I got my MS in health policy and management. I was like, I'm going to do big data epidemiologic studies and have a big impact on the world by like making real change. And then I realized, like, I hate big data sets. I hate data. I like can't. It wasn't for me. And so I switched into an implementation science track, which is like some really smart people gathered a lot of really important information. And now what do you do with that information? How do you implement it into practice to actually make the changes that other people have shown are effective? And so I found that side much more interesting. I'm much more interested in like the system and like the here and now. I did get my global health certificate at the time, also during my MS year. And then I got married, which was not super, we did plan to get married, but it wasn't in my big global health plan. And I like this picture of a wedding ring because it kind of looks like a handcuff, which is like the reality of marriage, is that I love my husband, but you have, suddenly 2 lives are merging, 2 goals are merging, right? Like I'm a very family-oriented person. I wanted to marry someone who was a family-oriented person. But that means that now you are oriented to their families also, which is great, but your straight arrow plan starts to change a lot. And so you have to, that's the reality of life, and we gotta take it as it is. So we hunkered down in LA, and I got an academic job at All of You UCLA with Alan, and I love it. It's a county hospital. We're working with underserved populations, underinsured, uninsured patients. Most of our patients are immigrants from Central and South America, and most people don't speak English. I love our patients so much. They're the best. And I get to teach. I am the fellowship director of the ultrasound fellowship, so I feel like I'm making a lot of impact in terms of like teaching residents, teaching fellows. So there's a lot of fulfillment that I'm getting. I love my job. It's like my dream job in terms of academic medicine. But I still had this like, come on, you got into this because you're going to Africa. Like, this is what you're supposed to do. You're failing at your life goal right now. Don't forget the big picture. But then more life happened. I had my first kid in 2020, and then COVID happened right after I had my first kid, which was terrible. And then, as we all remember, and then I had my second kid, and actually in between this time, someone asked me, will you come down to Tijuana and teach ultrasound? And I had just had a baby, COVID was going crazy. My husband's a very anxious person and was like, Tijuana is where everyone gets murdered, like, you can't go. And then I was like, no, I can't go to Africa right now, like, I have to go to Tijuana. It's 2 hours away, it's global health, I'm doing it. And so I did it. This Kareem, he was my fellow at the time. And who we got here? We got CK, she's one of the Mexican physicians in the clinic. And I think we have some of our pasantes who are like residents down there and a clinic coordinator. We went down, we all had our masks on, we did this huge educational session, and I loved it. And it wasn't Africa, but I was fulfilling my global health need, and I felt like I was bringing a practical skill that was being asked for. My whole goal of doing an ultrasound fellowship is now I have something practical to offer, and finally I do have an expertise that I can teach to somebody. And so we started going down there, and I'll tell you about that journey a little bit more, but I love it down there. And I've been trying to get down there every like 2 to 3 months. And then ultimately, this is where we are now. CK is actually teaching all of her clinic providers. So now what we've implemented is a train the trainer model. So CK, who was my student, she still is my student, but she is a physician, is now becoming the master of ultrasound and teaching to her providers down there. And ultimately, what I realized, there's a lot of like internal, I don't know if you guys can hear like the internal struggles that I was having going through this of like, I'm great, no, I'm terrible, oh, this is gonna be perfect, no, it's the worst. And I think it's natural to go through that, but ultimately, you just keep moving, everything you do, every experience you have adds and builds. And I tried to put myself in certain boxes, but reality is always gonna pull you back. And I think accepting that and doing what you excel at and just keep your head up and keep on moving. Okay, that's my inspirational talk. So let me talk a little bit about what I'm actually doing. So we partnered with the Refugee Health Alliance. This is an amazing nonprofit organization that is, the council is made up of Mexican physicians and physicians from the United States, and they just do amazing work. They have a clinic on the border in Tijuana, but they also go to shelters and provide medical care there, refugee shelters. So there's a lot of migrants from all over the world. Actually, there's a huge Haitian population that's just stuck at the border. They can't get across, and they don't have health care. And it's very, very expensive to be seen in the hospital in Mexico if you're not a Mexican citizen. And so, or if you don't have Mexican insurance. And so they provide free care for all of these people who are stuck at the border. And they also specialize in LGBTQ health. They provide hormone therapy, which is very rare. I think they're the only clinic that does it in all of Tijuana, which is a very large city. And they also have medical legal services. It's just like this wraparound, beautiful, free care. It's an excellent organization. If you have a chance to volunteer with them, I highly recommend it. They're wonderful, wonderful human beings. So I feel very, very privileged, is that the right word? I'm grateful to be able to work with such an amazing group of people. But teaching there has also been sort of a journey. The first time we went down there, we're like, we're gonna do this 2-day conference. We got a bunch of instructors. We set up a bunch of tables. We had, I don't know, maybe 40 students, all different learning levels. We had undergrads, we had nursing students, medical students, parteras, which are the midwives. Oh, that's another service they offer, is prenatal care, midwifery. And they also do like some acupuncture and like natural medicine as well. And and we had physicians both from the United States and from Mexico. So we had a very diverse group of students, which was great, but it also sort of made it complicated in the way that we taught. And we had a bunch of stations set up, and everybody was rotating, and we were teaching a bunch of different stuff. And it was great, and our students were engaged, and it was fun, but I don't think anybody left that 2-day conference using ultrasound. So it felt good, they enjoyed it, but was it actually impactful? I'm not sure. I think it was a good starter, but it wasn't enough. And so then I started thinking, okay, we'll go back longitudinally. So here I am in my second pregnancy, like super pregnant, teaching parteras about pregnancy, having them ultrasound me. We were trying to get down there regularly. And here's Jeremy, he's our current fellow, doing another small group session here in the clinic. And so then we decided, okay, like this longitudinal thing will be up better. But they also have a lot of rotating practitioners down there. And so they have some people who are full-time, but they have some people who are rotating. And when we're there, we love it. We're teaching everybody, but it still didn't feel like it was having the impact that we were hoping for. And so then we transitioned into this train the trainer model, where CK stepped up and was like, I will be the champion in our clinic, I'm gonna be the person, train me up. And so even then when we started, I was like, okay, great, I know how to do this. I train fellows, like you're gonna be my fellow, we're gonna have this intensive course, we're gonna meet online every week, you're gonna bring me all of these ultrasound images, I'm gonna review them with you, we're gonna come down once a month and do hands-on, and it just was too much. It makes sense in the US when you apply for a fellowship and your whole life is to do that. For someone who's running a nonprofit organization, seeing patients, and has a whole life and family of her own, it didn't make sense. And so what I envisioned as like the perfect plan, and she had initially agreed to, really didn't make sense in reality. So my implementation science side kicked in, and we're like, okay, we just have to like revisit this. What's working, what's not working, how can we do better? And I think that's like, in my global health experience anyway, you know, in terms of one really important thing is sustainability. And so we talked about having someone there who's, so that we want to make ourselves useless, right? We don't want to be dependent on. We want them to be independent. And so having someone who's actually there, speaking the language, teaching in Spanish, that's the goal. And so the train the trainer model is nice because now she is that person. But also that takes a lot of collaboration. I'm the expert, but she's really the expert in their clinical setting and what they're doing. And so we really need to bring our two expertises together and figure out, okay, what actually works. And then empowerment. And so I feel like a lot of my job is getting her from like, I can't do this or I can't do that, to I can. She has all the tools she needs, that she can build her own curriculum that makes sense. She can continue teaching in the way that she wants to teach, and ultimately will graduate to a point, I'm not there yet, sorry. Graduate to a point where she is coming up with all of she is making her own impact in the way that she wants to. So, Bree, am I like way over? I'm sorry. I'm so sorry. Okay, let me go quickly through this. The nuts and bolts of what we're doing. We do didactics once a month on Zoom, so I'm up here, they're down there, but we do some teaching that way. Hands-on training is always important for ultrasound. You can watch videos and lectures all day, but you must practice the actual physical skill of scanning. Alan Chim made this wonderful set of test questions on, what's it called, QStream, which is amazing, and we've taken some of those questions and tailored them to the clinic setting. We review images with her. This is also remote. And then we have a mastery learning model where basically we're like, this is what it takes to get to mastery. We'll test you and see where you're at. And if you're not there yet, let's see which pieces we're meeting, and then we can tailor our teaching to those specific things. And then we do the quiz again. And ultimately, everyone gets to mastery. It's just how many times do you have to go in that circle. And then what's nice about having built this curriculum is now she has it, and she's helping us. She's putting together these questions with us. She's building these modules with us, even though she's the one taking them. But creating them really solidifies the learning. And then she has these modules for when she starts teaching her learners who are rotating through there and her physicians who are there permanently. And so ultimately the student becomes the master, and then she can do what she wants with it. We're also collaborating on some research and further curriculum development. And so the last thing I would say, if you take nothing else from today's talk, is seek progress, not perfection. Because a lot of times, even what we think is perfect, whatever I think my goal is, that was at that season. In another season of my life, that may not be perfect anymore. Going to Africa doesn't make sense when I have a 4- and 2-year-old and my husband isn't comfortable with it. It's just life changes, bend with the wind. That's it, thanks.
Hi everyone. Well, my name is Paulo Aguilera. I'm in Chile right now at my home. First thing I would like to say is that I totally agree with what Jackie said in terms of how the only certain thing in life is change. And the whole careers, our careers is based on how we adapt to those changes and how things or priorities kind of adapts during your lifetime and during your careers. I would like to tell you a little bit about how mine changed and how ultrasound been important during the development of my whole career. So first, a little bit of an introduction from my side. I am a registered physician as well. I work in Chile as the EM director for a health network, which is named UC Christus, and which is related and works at the Catholic University. It's a big university located in Santiago. It's one of the most important one. And over there, I'm currently an associate professor, and I'm working at the med school level, also as a vice dean for international affairs or international relations. So my global health career has been part of this, and it's taken me to the spot I am right now. And many of these things had to be or are related on what I did in audition. So please give me the next slide. So this is me. That's how I got related with ultrasound. This is an Asian at one of the county hospitals that we work at. I worked there for 10 years. And I finished my residency around 2010. And I will tell you a little bit of the history of emergency medicine in Chile. But I would say that I was one of the first trained physicians. So that's all the main entrance of our main campus at the University Santiago. Is given the next slide, and that's the entrance of the University ED. Why? So we're out here in Chile. At the beginning, it all began around 1994. I wasn't born there yet. Okay. Yeah, but I was very young. I was not high school even. And we was trying to develop. So there was one of the initiatives of one of the universities in Chile, but it didn't go through as it was expected. So there was some time during a period, let's say more than 10 years, where having residents was more than a challenge. And many of the residents that went to emergency medicine, they ended up going to another specialty, surgery or internal medicine or cardiology or any other. And they didn't stay working at the ER because the hazard working there was too big and the income was bad, and all the bad things that can happen to you working at the ER happen to those them. So the training wasn't as continuous as we wanted to be. We were very alone. Give me the next slide. But I don't know if you know about Chile. Yeah, I tend to think you do. So Chile doesn't work. It's a long country, it's a tall country and thin country. We are we have around 20 million inhabitants, people that live there. It's one of the main well-developed countries on the region right now. And every year base we've been growing as a country. So it's not the difference between very well developed countries is not that much right now. But we do have long divisions or differences among the country. For instance, Santiago is a big city, and people that visit Santiago, they say it's a highly developed city. But if you move a little bit to the south, the river of Santiago, and then rural areas, there are huge need for emergency medicine and, of course, for ultrasound, and we've been trying to things everywhere. And I to know a little bit of that. So, thinking a little bit on what I was studying about in emergency medicine, a year 2002 or less, some of people from the U.S., mostly in California, these two very advanced physicians are well known. One is Dr. Billy Malin from USC, and the other one is Mina Herbert. She's right now like a faculty at UCLA. They both work together to support emergency medicine at its beginning, where it's in the beginning, since 2000, 2002 or 3. That's when the universities developed a little bit more. This you need a special slides. And this time we call it the Universidad Católica MUC was the third program to begin, and that was the program I was trained at. So after I finished residency, I went straight to emergency medicine, which it didn't exist at the Catholic University back then, but they were trying to design the training program very similar as the U.S. With the help of those people that we would see at the beginning, and then others joining this to Washington University under the Global Health Program. They helped us when developing the curriculum, which by then it didn't include ultrasound. getting a good result, point of care ultrasound. And well, as I finished, please give me the next one. Or during my residency, I have to say, we knew that point of care ultrasound was a thing that benefits our patients. We could make more certain diagnosis, and also we can do procedures. It was a thing we must know, we must learn. So by my own, I hooked up with some people in the US too, and I did some rotations during my residency. This was at Yale, emergency medicine department. I went there for a little bit more than a month, so I stayed there and I innovate. So I brought a little bit in order to look to my residency training program at the beginning. That is with that next month. And that was when we introduced it, and we began like spreading the word and what we could do locally with our ultrasound machine. So in that time, can you get that respect, please? The next, this is our class. And during that time, we had an old machine at the university department, very old, and I'll show it to you later. It's at the end of that. And with only one Kubernetes Pro, then it was when it was used by the surgeons. Usually they use it for the gallbladder, so gallbladder diagnosis. So that was what they did, and that was it. And first we didn't do anything. So one of the things I learned is really now, right now, is the basic things for emergency doctors and surgeons is trauma management with ultrasound. So I learned fast, and I began teaching people there and changing management, changing practice, changing our medical practice on a daily basis. So, give me the next one. I decided that this technology should be everywhere, and with my training program, I think I was like 2 or 3 years after I finished residency and teaching some of our faculty as well, that I decided, I have to say, I didn't decide it, I had the opportunity to do a fellowship in the US. And that was when people from UCLA, that by chance I met them in Santiago. They were one of the program directors was doing something with his wife. In the meantime, I went to visit our training program. We spoke about it, and he supported me with this application. With what's pretty new that some South American doctors were training on this kind of fellowships in the US. And that was when I met Dr. Chin back then, and I went to the US with my family in 2014. But in the meantime, we designed this kind of courses in Santiago. It's called Cernen UC, where we teach, or we continue teaching general practitioners, mostly that works outside in Santiago, and also even Santiago, and also other people from other specialties. And we do this course like 2 or 3 times a year, and it's very well evaluated by everyone. And that was first thing, education. And that's one of the secrets that ultrasound in emergency medicine. I will say emergency medicine in my country lead this area. And I was leading it because of medical education, because of what we did at the beginning with the ultrasound. That's the old ultrasound machine we had at the beginning. That's something like the clues of our success. Of course, we had lots of challenges. And in bringing taking the pro at the beginning, it was very hard because some other specialties, such as radiology, for instance, they see this as a challenge, not challenge, anywhere as a premise maybe, of that we could be a threat in the world with people for that specialty in ultrasound. Because we don't have text right now. We didn't have effects right now that we did was at primary doctor. So of course, I was an economic issue as well. But to the university and with my training, I came back in my country after I finished, and I began getting resources, trying to doing the politics to convince people at the university and the med school level, and also the industry to, at the beginning, to give us some ultrasound machines because we didn't have money for buying those. And we began teaching everyone. Not only right now, not only emergency medicine residents, but we also teach surgeons, anesthesiologists, in the med school. And we've been trying to develop this the undergraduate level, which is the next step, I would say. But right now it's another project that I have to build and to try. And with Alan, we've been discussing this to take ultrasound the undergrads, not only to medicine but to other careers as well. Asking you about in the U.S. what you like about having these opportunities and having this kind of activities where you can learn what is point of care ultrasound, which it really can make the difference. And we've been doing things outside themselves there to train people, and they're really grateful because this really changed your practice and change the things, change how you approach your really sick patients. Challenges are always there. You need to find your purpose, I think, in life. And in my case, I came back, as I mentioned, and our restoration department was struggling a lot at the hospital and at the rest of the other county hospitals. And I have the training in Pocus, and also I also did a medical education fellowship at UCLA as well. But they didn't ask me to run the departments as a chairman instead of doing ultrasound and that much. So, as I mentioned at the beginning, sometimes things happen because of randomly, because of luck, good luck, or bad luck. We can't realize it when it happens. But being there at that position made me able to help a lot more to develop both on the university level, also on an emergency department, administrative level, I could instead of justify where I needed an ultrasound machine, even though we didn't charge anything, which is in terms of money, you do it because of education, because it's important. And of course, my skills, because I skills during time have diminished a bit, but I've been always committed with my team because we developed a very strong team in ultrasound in South America right now, which have been able to also grow and do things in other countries of the region. And I've been supporting this. I wish I could do more, like hands-on things, but with my career, as I mentioned, things changed. Things happened not the way I had planned, but at the end, I was able to help develop ultrasound and also to develop emergency medicine in my center. Right now, we're the biggest training program in Chile. Have a lot of residents, have a lot of people that are coming among our region and from other countries, from Europe as well, Spain, and they wrote it with us. They learn ultrasound and learn emergency medicine. We get people from a lot of specialists as well. We give labs, and med students want to rotate and with our team, with that specialty in Santiago, and that makes me very happy and proud on what we've done in this, let's say, maybe for 2 years at our center. And it's been an awesome career and an awesome journey. And that, it's what happened. That's my last week. I can play the video. It's a show, man. So, very rich. I was sorry if I took more time than needed. If it doesn't work, it's a previous highlight. That you pay. Yeah, sorry about that. That's an opinion. Can you click on that if it works? Let's see. In Brazil, it's okay, but it has like a video on. everything. So, well, yeah. If you with that, it's fine. Let's say if you with that with our first person machine, so that patient came in with small injury in his chest, was like maybe 32, I think it's less. We put ultrasound probe and it was with a cardiac tamponade, and we could diagnose that with the carbodynium probe. And I was able to convince the surgeon who was there, even though he hits it with I pushed the words, he's stable, it's thinking and breathing. And it suddenly see it's really bad. We do things the older the identity testing, and that's what is taking space looking in China. As a specialty, we want the respect from the surgeons we work with. And that was this patient that changed everything at our county hospital. And that's what I have to say. So keep on going, believe in yourself. You have to dream huge, dream big, and get things done. That's where we get nice things happen. So thank you.
Thank you, Dr. Aguilera. Awesome. I think we might be running out of time here, so 2 minutes, okay. I was just going to give a quick survey of like other, kind of the applications of Pocus in like global health, and kind of like TLDR. I have a background in global health. I did a master's program at Tulane under the Global Scholars Program, and I served for 3 years in the Peace Corps, and 2 years was here in the Gambia in kind of a little fishing village here on the coast. And then the last year I kind of was like a chief resident for Peace Corps, where I was helping to train other volunteers, but then I also worked as a project manager for the National AIDS Secretariat, which is like the National AIDS Office in the Gambia. And that gave me a really broad exposure in terms of like what's happening on the ground and also what is happening at the higher levels. And I just wanted to show that one of the major obstacles, and it's a common theme in some of these talks, is that there's really a lack of access to imaging technology. Here's an example of this. There's one CT, there's one MRI here all in the urban area, but there's really nothing else. There are a few X-ray machines, but most of the health centers do have ultrasound machines, and that's a really common theme. So this tells you, like, in terms of screening, this is actually from for breast cancer, but it could be used for anything, any diagnosis, any management. And the idea is that, like, the darker it is, the more at risk, the more the disparity. Like, there's no imaging here, there's no imaging on the East Coast. And the same applies to many of our medical problems. And one is this trauma care. There was a theme about like getting to know the system. Well, the Gambia has a high mortality rate from traumatic accidents, especially motor vehicle accidents. And one major issue is just not knowing how to identify which patients need to get operative management emergently versus those that can wait. And the reason is not only for imaging, but also surgical care. There's basically like less than 10 surgeons in the Gambia, and most places that are underdeveloped have this same problem where you have a brain drain syndrome. A lot of people that are trained, they go overseas to practice because it makes more sense economically to do that. And I just want to highlight this one article where this was actually I believe in Tanzania, where they just kind of implemented the FAST exam. The FAST exam is called for focus assessment with sonography and trauma. And basically, when they had these patients that came in with motor vehicle accidents, they had a FAST exam, and about 40% had a positive FAST. That's like tremendously high. So these are patients that are coming in really sick. And that I would say the FAST rate at UCLA or Harvard is probably under 5%. So that gives you an idea of how bad it is. And all of those patients were rushed to the OR, and they all have positive findings. And I think like if you guys are coming for the second session, you'll have an opportunity to kind of take a look at this. But this is something that is really a very, very simple maneuver that you can do where you're looking for fluid between the liver and the kidney here on the right side. And that is a very, very common place for blood to accumulate. And if you see a sliver of blood like right here, that helps you to prioritize care. So if a patient is on the kind of like 100 kilometers away from the capital, they can actually be rushed straight to a surgical center. Versus patients that have trauma and they may not have free fluid like this, those patients typically have time for kind of watchful waiting. I also wanted to highlight, I know we're wrapping up, another major barrier to really great healthcare in most places, and that's the lack of anesthesiology. Not only the anesthesiologists are responsible for taking care of the medical side of patients when they're undergoing surgery, and so anesthesiologists are just hard to come by, and on top of that, you have ventilators that are really, really complicated and hard to manage. You need to sanitize them all the time. I think like there's some really great reports out there from WHO and UN about how electricity is a major issue running water. So you can't really have something high tech like a ventilator here without undergoing this process, without surgeries, and therefore surgeries are delayed. And some patients actually don't get to go to surgery. This is actually a study from MSF, the Doctors Without Borders, and it just shows like the disparity in terms of the perioperative death, like in terms of patients that go through with general anesthesia versus with regional anesthesia, which is what I'll get to next. So let's say if a patient has a broken arm, broken wrist, they need to go to the OR to get it fixed. You have an orthopedic surgeon miraculously there, but you don't have the anesthesiologist. So what can you do? There's something called the brachial plexus here, and if you guys go to medical school, you'll learn it intimately during your first year of anatomy, and you'll know that actually supplies motor and sensation to your arm. So if you're able to block, meaning you're able to inject anesthetic around that arm, around the brachial plexus, you can actually have a patient who's completely wide awake, but they won't feel anything at all. And it's safer for them because they're not on a ventilator, they're not having to deal with sort of the changes that you have in physiology when someone's on the ventilator. So this is one example. This is actually how we look at it on ultrasound. This is a major artery that's kind of running around your clavicle here, the subclavian artery. And then this is actually the brachial plexus here. So you could see that there are these like little dark circles that are coming between these muscles. Well, these are actually the roots that come from your brain to your neck to your arm, and they supply both your ability to move your muscles and to sense. So imagine being able to do a really complicated surgery where you're plating bones, and then at the same time you're basically able to do the surgery without a ventilator, without an anesthesiologist. And this is happening right now, and this is why I think like MSF had this kind of review. I just wanted to show you what it looks like, and I think this I'll stop there. But here's like there's a median nerve, and this is a needle under ultrasound. This is a nerve that supplies sensation to your palm. So let's say you have a really big laceration, and you need to explore it. Maybe you have a broken bone, et cetera. You need to fix it or reduce it. Well, if you inject anesthetic around the nerve right here, it actually will kind of numb up the entire area. So this is the needle tip, and it's going around the nerve. And in a minute or two, the patient will say, "I cannot feel my palm at all." And then this is actually a little bit more complicated. I think this is. Let's see if I can get this to go. Yes. So this one right here is similar to the brachial plexus block, but this is actually something called the stellate ganglion block. Try saying that like 10 times fast. So this is actually, this block right here will will actually supply everything from sort of like your ability to dilate your eye, your pupil in your eye, to sensation around your neck, to also slowing down heart rates. So if you have someone who has a fast heart rate, this is kind of like considered like a potential last line therapy to do that. And so you have your artery here. You guys can all palpate your carotid artery. And then just a little bit to the side, you'll have a big vein, but in between, you actually have two really important nerves, the vagus nerve, which is kind of between the two vessels, and then this stellate ganglion, which is underneath the carotid artery. And here you could see the needle going in. And when you inject just below this nerve right here, you're going to have a really, really great anesthetic effect. So patients can go through a lot of the different surgeries that we talk about. I think, yeah, we are running over, so I just wanted to stop. And hopefully you guys got a chance to if you guys come back in the second session to practice. Thank you.